way we don't hear any babies crying or dogs barking. If you hear any dogs barking, it'll be mine. Okay, so let's move on. Bear with me for a moment. Not on my own computer, so I apologize for that. All right, so I'll tell you a minute or two a little bit about who I am, because always good to know who's speaking. I'm a chiropractic radiologist, chiropractor, graduated from CMCC, Canadian Memorial College in Toronto, back in '83. I went on to do a full-time radiology residency at what was then Los Angeles College of Chiropractic. It's now Southern California University of Health Sciences. It was a 3-year program. I studied under Dr. Joseph Howe, who is the grandfather of chiropractic radiology. I'm actually the only chiropractic radiologist that's ever studied under 3 generations of chiropractic radiologists, because I also studied under Terry Yoakum and Lindsay Rowe. Lindsay was my professor at CMCC in 4th year, and Terry was a visiting professor at Los Angeles College, and also you're all familiar with his textbook. I had the privilege of working on that textbook, editing it, doing some drawings, and helping to proofread it. Back when he was writing the first edition of the textbook, he needed a resident to come out to Denver, where he lived, and help him finish the book and meet the publishing deadlines. Unfortunately, Dr. Howe picked me, and it was an amazing experience where I basically lived with the Yoakum family for a couple of months, about 3 months, and it was great. We became very close friends, and I basically lived with his family, took the kids out for Halloween, and we did everything together. It was wonderful, great experience. Most of what I saw of Denver was the basement of his house as I did the proofreading. So subsequent to that, I've also helped start the chiropractic program at the University of Quebec at Trois-Rivières in Quebec, Canada, which is the only university affiliated chiropractic program in Canada. And I taught all the radiology courses there in the first couple of years in French, which wasn't easy. I had to stand in front of the class with a dictionary, and the students wanted me to speak English, and I had to practice my French, but worked out great. And they finished #1 in North America on the radiology boards in the US and Canada, so that was terrific. Been in private practice for quite a number of years now. I was in Toronto doing an X-ray taking and reading practice, and then that switched over to an X-ray reading practice, and now I read X-rays for chiropractors from around the world online. I'm also a professor of radiology at Barcelona College of Chiropractic. That started a couple of years ago, and been helping that school grow as well, and it's a terrific place. Okay, let's move on. You see Yoakum's book there in the top left. That's the first edition that I helped put together. I've done a lot of writing. The book in the center, Portable Skull X-ray Library, that's a book that I authored. It's kind of a Reader's Digest version of Yoakum's book. And a couple of book chapters, one in chiropractic cardiac patients and one in craniocervical syndrome. I've also done quite a number of journal articles in both medical and chiropractic journals. I sit on a number of editorial boards as well. I've had the privilege of lecturing at a number of different countries, both in person and on Zoom, mostly in Canada and throughout Canada and the United States, many states and many provinces in Canada. I now live in Israel, and so I'm a little more accessible to Europe, Asia, and Africa, and was doing some traveling until the whole pandemic thing started. And now, fortunately, we can do things on Zoom, which I think is in some ways preferable, because we can get a lot more people coming out to the seminar, and you can sit in the comfort of your own home, save travel expenses, and put me on mute whenever you need to. Okay, so for this first session, what I want to do is go through a 12-step kind of program of how to approach X-rays. I know that X-rays are a source of anxiety for a lot of people. One of my other experiences was in the regulatory world. I was the president for a year and on council of the Regulatory College for Chiropractors in Ontario, Canada. And this is a very large organization that licenses chiropractors. There's close to 5,000 chiropractors in Ontario, Canada alone. And I sat on many committees and chaired discipline committees and quality assurance and registration, those type of things. And the reason that I put this slide up to improve your communication through a logical approach is I found that in complaints, I sat on complaints for several years, and discipline, that one of the main issues is that there's a lack of communication, a communication breakdown. It's either between you and a colleague, or you and a patient, or you and a medical doctor, or you and a lawyer. So if you can keep your communication standard and thorough, then I think you have less chance of ending up at a discipline hearing or some type of civil court proceeding. How do we do that? One of the main ways is record keeping. Keep proper and complete records, write everything down. It was always taught that it's in the patient's best interest for you to keep proper records, but you know what? It doesn't particularly protect the patient, it protects you as the doctor, because patients don't keep records. And if it comes down to a hearing or a complaint being lodged against you, it tends to become a he said, she said type of thing. But if you have documentation, and x-ray reports, x-rays are part of that documentation, then it's less likely that you're going to be on the wrong side of the decision. Okay, so that's kind of an overlying theme for today, particularly. So what we're going to do is we're going to review some common and conventional ways of describing things on x-rays so that you'll feel more comfortable with that. And when things seem a little too dramatic or a little out of hand, then there are chiropractic radiologists like myself. There's several at your schools as well that you can speak to and communicate with as specialists within our profession. Okay, so we're going to learn how to, or review how to describe a lesion. I'm going to show you kind of a logical sequential approach of how to do that, categorize the lesion, and then hopefully provide a diagnosis, or at best maybe a differential diagnosis. Sometimes we just don't know the diagnosis based on x-ray alone. There's other factors we have to incorporate, things like lab and so on. Okay, I'm not sure how many of you are familiar with this designation of the different entities that can affect the bone. Sorry, I don't know why that's on the screen. There we go. Okay, perfect. The Catbites categories, and Catbites stands for the different types of bone pathologies: congenital, arthritis, tumor, blood, infection, trauma, endocrine, soft tissue. Congenital are things like the anomalies, all the various types of anomalies, cervical ribs, facet asymmetry, those type of things, kind of the more mundane things, but also include some of the weird and crazy dysplasias that are very rare, and that would fall under the congenital category as well. And under arthritis, we're looking at basically 2 or 3 different types: the degenerative type of arthritis versus the inflammatory type of arthritis. And as we get on in the course of some of these sessions, we'll see examples of those. The metabolic types of arthritis, where there's deposition into the joints. Tumor, we're looking at how to tell the difference between benign tumors and malignant tumors. We'll spend a little bit of time on that today. And then within the malignant, how do you tell the difference between a primary tumor and a secondary metastatic tumor? And there are key radiographic features that will help us hone in on one versus the other. Under blood, we're looking at the hematological disorders, such as the anemias, not that common, and more commonly avascular necrosis, the different types of bone death and what happens when a bone loses its blood supply, and how that appears on x-ray, and how that gives us clues as to what we're looking at. Infection, we're looking at mostly 90% Staph aureus, suppurative osteomyelitis, infection of the bone, and then also septic arthritis, what happens when infection affects the actual joint space, and how to tell the difference between an infection and a tumor, because both can be considered, aggressive lesions, depending on the nature of the infection and when you're catching it. Okay, then we go into trauma. Trauma is basically the different types of fractures and dislocations. And yeah, a lot of them have names based on who first discovered it or identified it. But the names aren't as crucial as knowing how to conventionally and properly describe a fracture or a dislocation, and we'll get into that as well. Endocrine are the metabolic and nutritional disorders, again, pretty rare, except for the most common, which is osteoporosis, and we'll be looking at some osteoporosis examples as well throughout the course of the different sessions. And then finally, we have S, the soft tissue. These are either diseases that originate outside of the skeleton and then affect the bone extrinsically, or the different types of, and including the different types of ossifications, calcifications, that sort of thing. Is it a vessel? Is it a stone? And where is it located? So soft tissue is an important part of categorizing different pathologies. Okay, again, if there's any questions throughout, feel free to type it in. I'm looking out for any questions or comments. I want to go at a decent speed because you're all at different levels, and I want to make sure that we're kind of all on the same page. So now we're going to go through the 12-point approach, the logical approach to looking at films. These are the first 4 in terms of how to describe a lesion. These are 12 steps to how to describe a lesion. Okay. Number 1 is the number of lesions. How many lesions do you see on the X-ray or on the series of X-rays? Is it a monostotic lesion or a polyostotic lesion, right? Does it affect just one bone? Is it localized? Or is it on every bone or virtually every bone that you see on the film? That's going to be a clue as to whether we're looking at something local or something systemic, for example. Okay. Number 2, and I do promise we're going to look at some X-rays pretty soon. Number 2 is the location, just like real estate agent, location, location, location. And within location, we know that some diseases have a predilection for a certain region of the skeleton. Some prefer the axial skeleton, some prefer the appendicular skeleton. And then within a bone, certain diseases like the epiphysis, some like the metaphysis, and some tend to be attracted more to the diaphysis. So location is really 2 main components. Where in the skeleton is the lesion occurring, and where in the bone is the lesion occurring. These are, again, clues as to what the diagnosis may be. Next is the symmetry of the lesions. Are they equally distributed throughout the film or from side to side? Classically, for example, you may recall that rheumatoid arthritis is something that is bilaterally symmetrical. So you're going to see both sides of the body affected relatively equally. Whereas asymmetrical or haphazardly arranged lesions suggest something else. Perhaps another example of that would be, let's say, metastasis, which has no pattern of distribution. It's just kind of haphazardly all over the place. So that's some examples of symmetry and asymmetry. An important part of a description is the size of the lesion. So measuring the lesion, and of course digitally, we can do that quite easily. I can measure on some programs to within a 10th or even a 100th of a millimeter on some of the programs. Angles, you can measure to within at least a 10th of a degree. So it's great having the technology and not having to resort to the old pencil and ruler, which is what I was trained on originally. So one other thing about size, and even though size is an important descriptor, it doesn't indicate the aggressiveness or the seriousness of a lesion. Remember that. You can have a very large benign cyst, and you can have a very small metastatic focus. So size is not an indicator of the aggressiveness or the malignant potential of a disease, but it is an indicator as you're getting subsequent films, the growth and the rate of growth of a lesion could be an indicator more of the aggressiveness, but the size itself does not indicate necessarily the aggressiveness of the lesion. Okay, more. Okay, we're going to start looking at X-rays in a moment. Number 5 is the margin of the lesion. The margin of the lesion is basically the border of the lesion, and there's really, as you'll see as we go through these different 12 points, I try to keep it very organized so that within one point, you only have 2 to maybe 3 choices. With the margin lesion, there's only 2 things that it can either be well-defined or ill-defined. Either you can really clearly see where normal bone ends and abnormal bone begins, or you can't, and it's blurred and smudgy. We'll have a look at both. Now, well-defined is also known as having a narrow zone of transition, meaning it's a very sharply defined border. It doesn't have to be sclerotic. Sometimes it's a sclerotic border. But the key thing is, yep, I can see very nicely, this is a very localized lesion. You'll see later another term is geographic lesion or focal lesion, other terms that we've used to describe things that are well-defined. It's very easy to see, again, where normal bone ends and abnormal bone begins. We'll get into ill-defined in just a moment. I want to show you an example of a well-defined lesion. Here we have a lateral calcaneus, and there's a cyst, a simple bone cyst, in the inferior aspect of the calcaneus. And you can see that it's quite well defined. It's lost its trabecular pattern, and it's ovoid or egg shaped and filled with fluid in this particular case. You can't tell from the X-ray. You'd have to do biopsy to tell that for sure. But that's not necessary, or MRI might be helpful at this point as well. I wouldn't necessarily indicate taking an MRI for this particular case, and this was probably found incidentally. Maybe the person twisted their ankle or just came in and had a foot X-ray, and all of a sudden this shows up on their calcaneus. It's totally incidental here, but just to show you an example of a well-defined margin. The alternative to that is an ill-defined margin, which is very blurred, very smudgy, and also known as having a wide zone of transition, because now the border between normal and abnormal is going to be very wide and hazy and not very clear. This is more of a sign of an aggressive lesion. Okay, there we see in the proximal femur, we're looking at the femoral neck in the upper right, reading right corner. If we look down at the very bottom, we can see that there's normal cortex, normal medullary bone, and normal cortex. And as we move up, move cephalad towards the top of the femur, we can see patches of sclerosis and patches of lucency. We've lost the normal trabecular pattern, and this is certainly very characteristic of an aggressive lesion. In this case, it is a neoplasm. This is the start of an osteosarcoma. And again, diagnosis not as important right now. We're just going through some descriptive terms. We'll get into diagnosis in a little bit, or probably in our next session. Okay, so this is ill-defined and aggressive lesion. When you think aggressive lesions, two of the Catbites categories you should be thinking of are neoplasm, an aggressive neoplasm, or an aggressive infection. And sometimes they can look pretty similar. There are some ways to tell them apart on X-ray. Okay, number 6, cortical integrity. Now, again, there's only two choices. Either the cortex is intact or the cortex is broken. If it's intact, it presents in one of three patterns, either a thin cortex, a thickened cortex, or an expanded cortex. Okay, we'll look at that. Just a moment. I'm just going to try to move I have a chat box here, and I just want to move that so I can get it out of the way. Okay, if it's broken, there's only two ways that the bone can break. Either an external force through either healthy or unhealthy bone causing a fracture, or it can be destroyed through some type of internal process, infection or neoplasm. Okay, so let's look at an intact thin cortex. There we go. Okay. What we're looking at in the distal radius is an area of, you can call it bone rarefaction, decreased bone density. It's a very well-defined area as well. But if you'll notice by the ulnar aspect, let's see if I can get my pointer there. For a second. Okay, maybe let's see that arrow. Right along here, it's a very thin cortex, still intact, and it has not changed the shape of the bone, but it's thin because of the replacement of this normal bone trabeculation with abnormal bone. You can certainly, anyone that wants to make a hazard a guess as to what this is can type in the chat what they think it is. Again, not as important as just seeing the example of a thin cortex, intact cortex. This is a benign lesion. Okay, anybody want to guess? Not yet, too early? Okay. All right, this is a giant cell tumor. It's a classic giant cell tumor in the distal radius with the internal septations that's known as a soap bubble appearance. We're not going to get into the details of the tumor at this point. More to show you that it's intact and thin and maintains a shape. Now, this could be found incidentally. There may not be any pain here, but more likely it would be found if this person fell on their wrist and fractured along that thin cortex. Because it's a thin cortex, it's prone to pathological fracture. And that's probably why someone would present with a giant cell tumor. It's not in and of itself a space-occupying lesion because it has not changed the shape of the bone. Okay, so it could be found pretty incidentally or following a pathological fracture. Okay, thickened cortex. Okay, here we have a vertebral body, lumbar vertebral body. We're looking, the left side is the front of the vertebral body. Sorry, one moment. So the reading right is the front of the body. The arrow is pointing to the relative loss of the normal concavity. Posterior elements are on the left side. And you'll see that the cortex of this vertebral body is thickened and irregular. This is known, the radiographic sign. Anybody remember the name of this radiographic sign? Type it in. I'll give you a moment to see if anybody wants to try. Okay, nope. All right, this is the picture frame vertebra of combined phase of Paget's disease. But again, don't expect you to get the diagnosis or necessarily, I don't care about the diagnosis right at the moment, just to show you that cortex can be thickened, it's intact, it's abnormal bone, it's a bit of a bone softening disease, and that's why the vertebrae seems a little compressed. In Paget's disease, it's actually enlarged and squared off, and that's why it's losing the anterior concavity. But this is the picture frame vertebrae combined of Paget's disease, combined phase. Remember, Paget's has 4 different phases. You have the lytic phase, the combined phase, the sclerotic phase, and then in some cases you can have malignant degeneration into a Paget's sarcoma. Okay, and next, still with an intact cortex, we have the expanded cortex. Now here, I want you to compare this to what we saw in the distal radius. Here we see in the proximal fibula of a child, and we know it's a child because we have the physeal plates have not totally closed here yet in both the proximal tibia and proximal fibula. Here we have a very expanded cortex. So the cortex isn't only thin here, it's expanded, it's changed the shape of the proximal fibula, and therefore it does kind of act as a space-occupying lesion. This is going to compromise the common perineal nerve that comes around the top of the fibular neck, and probably some blood vessels as well. There's going to be a cosmetic deformity. There's going to be a bulge in this kid's calf. So this is going to be a space-occupying lesion and is going to cause symptoms and will not be found incidentally. Certainly, of course, and remember that we're talking about a shell of bone that's going around in 3 dimensions, not just a thin linear calcification. This is basically a shell of bone, like an eggshell, if you will. It's very thin and therefore quite prone to pathological fracture, especially this area where any kid falling in the playground could get this fractured, particularly on the lateral side. Okay, so this is any thoughts as to what this one is? Anyone want to guess? This is the only lesion that's named for something that it resembles rather than for its cellular components. You know, most of them are named osteo something, chondro something, fibro something, depending on, and we'll talk about that in a few minutes, why it gets its name. This one is not. It's named for what it looks like. Any thoughts? Yes, very good. Okay. Carolyn, yeah, actually, yep, good. That's what it is. This is an ABC, an aneurysmal bone cyst, because it's blown out like an aneurysm. That's exactly right. So this is an ABC in the proximal metaphysis of the fibula. In and of itself, it probably will cause some type of symptoms. It probably will have a cosmetic deformity, and it's certainly really prone to pathological fracture. Good. Let's look at broken cortex. Actually, I'm going to get a prop here before we continue. Just bear with me for a second. This prop will help explain the next X-ray. All right, so we're looking at a fractured wrist. And again, I don't care if you know the name of the fracture. You may, and if you like, you're welcome to type it in. But what's most important is when you're describing a fracture, you have to do it conventionally, the way medicine and orthopedics describes a fracture. And that is to describe the fracture, first of all, the distal fragment, how it's moved in relation to the proximal. We always talk about the distal, how it moving with relation to the proximal. And second of all, the patient is in anatomical position. So here we see a fracture of both the, Javini wants me to mention to you that there's an attendance register in the chat, and when you have a chance to please complete that. Yes, very good, Dr. Story. This is a Colles fracture. bilateral fracture of the, I'm sorry, not a fracture of both the radius and ulna distally with, you can say it's dorsal movement of the fracture fragment. It's posterior, because remember we're talking about anatomical position, so it's a posterior shift of the fracture fragment. And this is also known as the dinner fork deformity. And the prop that I wanted to bring you is an actual dinner fork here. And you can see, so hold it up to match the orientation of the x-ray, and you'll see why it's called a dinner fork deformity, because the posterior migration of the radius and ulnar fragments moving posteriorly or dorsally makes it simulate the handle of the fork turning into the tines of the fork shape. Okay, dinner fork deformity. Very good. Actually, let's move on. Okay, and the other way, of course, more ominous way of losing cortical integrity is with internal destruction. And yeah, here we see something a little dramatic. We'll leave it for a moment. What we see here is patchy areas of bone destruction, increased bone density in some patchy areas, and let's go to the. You see these striations of bone radiating from this central lucent area. This is referred to as the sunburst periostral response. Sunburst periostral response is a sign of an extremely aggressive lesion. This is actually an osteosarcoma that used to be someone's jaw. You can see some teeth. There's a molar and hyoid bone there, upper jaw here. So this is someone's mandible that is afflicted with osteosarcoma. Extremely, extremely aggressive. You'd expect an osteosarcoma, as the name suggests, it's a neoplasm of bone growth, a neoplastic bone growth, and it is. So then you might ask, well, okay, I see the bone growth here. This is very sclerotic. You don't see any trabecular pattern. There's just tons of new bone here. Why is this so lucent if there's new bone growth? The reason is because the neoplastic osteocytes are growing so fast that you're catching them at a point where they haven't even ossified yet. So these are really growing new, and it's just a lot of expansion and growth into the soft tissue. I'll talk about periosteal reaction in a couple of minutes. We'll get into that because I know that is a source of confusion for some people. Just to show you, this is a very aggressive lesion. Okay. All right, number 7. So we've covered 6 of the 12 categories so far. Timing is looking fine. 7 is the effect on the bone. What is the lesion doing to the bone? And there's really only 2 things it can do. It's either going to decrease the density, therefore it's a lytic lesion, or it's going to increase the density, and therefore it's a blastic lesion. When we're talking about things like metastasis specifically, lytic accounts for about 70% of METs, blastic for about 20%, and you'll see letter C, about 10% are mixed. Very rare to get mixed metastasis. So lytic lesions can be aggressive or not aggressive. And they run the gamut from geographic through moth-eaten through permeative. And we're going to look at geographic first, but you see the 3 subcategories of lytic. Geographic, moth-eaten, and permeative are a spectrum of going from the least aggressive or most benign to the most aggressive, which is permeative. Okay, so again, lytic is loss of bone density, and it can be in a geographic pattern, a moth-eaten pattern, or a permeative pattern. So let's have a look at those. Okay, geographic first. We've seen some examples of geographic. The other names for that are a focal lesion, a localized lesion, well circumscribed lesion. There's a number of different ways you can use the art of chiropractic to describe your local lesion. Just get over to the pointer again. Actually, I think I can use this one. No, that's not what I want. Let's use that. Okay, so here we see an aneurysmal bone cyst, just as we did before. This one's not as dramatic. Person's a little older here. The physeal plates have closed. And you might see right there's a little bit of angulation. There could be a little crack there. It might be a pathological fracture, and that might have been what brought this person in. Anybody see anything else? So an aneurysmal bone cyst, geographic, local, well-defined. That's very benign, sign of a benign lesion. Unfortunately, I don't have a lateral in this one too, but I want you all to look at this tibial tuberosity is quite loosened. It's even has a bit of a scalloped margin right around this area here. And that's a non-ossifying fibroma. So this guy has a 2-for-1 deal. He's got a NOF and an ABC. Okay, again, geographic, well-defined lesion. Okay. Now we're going to look at moth-eaten. And as the name suggests, this bone looks like it's been moth-eaten. Basically, the textbooks describe this lesion as being multiple lytic lesions that are typically 3 to 5 millimeters in diameter. But of course, as the pathological process progresses, these lesions are going to coalesce into larger lesions, and that's what we see happening here. But this is, I can't tell you for sure what this is. This could be lytic metastasis, or it could be the most common primary tumor of bone, which is, you may recall, multiple myeloma. Looks the same. Same age group. The main differential would be to do a bone scan. In lytic mets, the bone scan is going to light up all over the place. And in multiple myeloma, rather, the bone scan is going to be cold for various metabolic reasons, chemical reasons, biochemical. Okay, so this is, again, kind of multiple lytic lesions, typically 3 to 5 millimeters, and you really can't tell where does normal bone and abnormal bone begin. The geographic, of course, you can, and that's why it's a benign lesion that's typically found incidentally unless there's pathological fracture. Okay, let's look at permeative now. Permeative is, as the name suggests, where the abnormal bone is so permeated within the normal bone that it's really impossible to tell where does normal bone end and abnormal bone begin. They've just merged together, and we're going to have a look at that one right now. So here on the reading left, we have a normal shaft of the femur, and on the reading right, my pointer back over. I'm switching from like one computer to another monitor here, so ask you to bear with me. Okay, right. Along in this area here, you can see tiny little pinholes of darker gray in the medullary cavity. So that's the lesion. This is lytic metastasis. It's really advanced lytic metastasis where there's complete integration of pathological bone into what would have been normal bone, and there's no way of separating the two. That's a sign of an extremely aggressive lesion. So again, just as a quick review, we're going lytic lesions, bone destruction. It can be geographic, which is the least aggressive and usually benign, into moth-eaten, which is semi-aggressive, and then permeative, which is the most aggressive. You tend to see moth-eaten in slower growing tumors or in more like a serious infection. And the permeative, you're going to see more in the aggressive type of metastasis. Okay, blastic, as the name suggests, now we're going to see increase in bone density. Give you a moment to see if you guys remember the name of this radiographic sign. We have completely homogeneously dense, homogeneously white vertebra. Remember the name of this. Right, good. Yep, this is the famous ivory vertebra. Yep, that's right, the ivory vertebra. And typically, there's 3 differential diagnoses for an ivory vertebra. I'm going to kind of go a little bit off track so I can get a bit of differential diagnosis while we got this case up. Anybody remember what the 3 main types of blastic lesions or ivory vertebra would be? And then we'll look into why it's one of those 3. Okay, what's the first one? Anybody want to put one down? Any thoughts? Paget's, great. Yep, Paget's is one of them. Yep, the sclerotic or third phase of Paget's will definitely give an ivory vertebra. What else? 2 more things. Good, Mets. Yep, blastic Mets, typically from lung or breast in females, and prostate's classic in male patients. Blastic metastasis for sure. And one more. Anybody remember this? Those are the two that are more typically remembered. Third one, not so much. Give you a moment to type. Yep, excellent. Yes, Hodgkin's lymphoma. That's right. Very good. Hodgkin's lymphoma. So those are the three: Mets, Paget's, or Hodgkin's lymphoma. Now this vertebra, this eye vertebra, is clearly one of those three, and there's clues as to why it's one over the other. So let's look at Paget's first of all. Could this be Paget's? Anybody think this is Paget's? Well, I'll save you a moment and tell you it can't be Paget's. Why not? Paget's does a couple of things to the vertebral body. It enlarges it or expands it. You can see this vertebra is pretty much the same size as its neighbors. So that's one strike against Paget's. Number two, Paget's, because as the vertebra is growing with abnormal softened bone, it tends to square off the anterior margin and lose that anterior concavity. This vertebra has maintained its normal anterior concavity. So it's basically the same size and shape as its neighbors. So Paget's is ruled out. Okay, let's look at Hodgkin's lymphoma. Hodgkin's lymphoma will give an ivy vertebra, but it does something a little bit different. Because it's a tumor of the neoplasm of the lymph nodes, and there are paraspinal lymph nodes. Let's see if I can bring my pointer back over. Yeah, paraspinal lymph nodes, both on the sides and on the front of the vertebral body. And those lymph nodes become neoplastic, and the neoplastic tissue starts to grow and fill up the capsule of the lymph node. It's going to become very hard and very engorged, I guess you could say, to the point where if it's there for a while, it's going to cause pressure erosions into the vertebral body. And so what you're going to get with Hodgkin's classically is an increase in the, there, maybe not that much, but I'm just going to overemphasize it. You're going to get scalloping and an increased anterior concavity in Hodgkin's disease. So based on what we talked about so far, I think we can conclude that we're looking at a metastatic blastic metastasis, probably from prostate if this is a male patient, more than likely, because the vertebra has maintained its size and shape. And also, for those of you who are a little more eagle-eyed, you may have seen a little blurry, ill-defined focus of Mets in the vertebra below. If you didn't, I'll make sure that one of these sessions you'll get my email address. If you have any questions about X-ray, you're welcome to contact me. That's my only commercial. Okay, let's move on. And finally, as I said, 10% of the Mets will be mixed. And this is an example from an old textbook, Dr. Earl Rich, the great-grandfather of chiropractic radiology. He taught at the school that doesn't exist anymore, Lincoln College in Indianapolis, which merged with National in Chicago. So you'll see areas here. Here's blastic areas, lytic area. Here's this acetabulum is lytic, this acetabulum is blastic, this pubic ramus is lytic, and here the whole issue is blastic, and the sacrum here, blastic with some lytic areas around the sacroiliac joint. It's just like a mess all over the place. Don't see it that often, fortunately, but just wanted to show you to be complete an example of mixed metastasis. Okay, number 8, the matrix of the lesion. This is the one that tends to give it its name, primarily osteo, if it's osseous, and then you have like cartilaginous, fibrous, and fluid. So we're going to look at osseous first, then cartilaginous, the chondro, and then fibrous and fluid. Now, fibrous and fluid can look very similar, and it's very difficult, if not impossible, to tell them on the difference on plain film. Osseous, as the name suggests, the primary connective tissue that's neoplastic here is going to be bone, and therefore you're going to expect to see extremely dense bone formation, total replacement of the medullary cavity with essentially cortical bone. It's just tons and tons of new neoplastic osteocytes forming. This is an extremely classic, very aggressive osteosarcoma here in the knee. It loves the knee. That's its favorite spot, the distal metastasis of the knee. You'll see that there's just lots of new bone formation. In fact, there's actually pieces, chunks of bone expanded out into the soft tissue. And remember, this is all in 3 dimensions all the way around. This tumor has just completely proliferated osteocytes, neoplastic osteocytes. And this is called the cumulus cloud appearance because it just looks like a giant cloud of neoplasm. What's interesting to note is, and this tends to happen in more like late teens or early 20s typically, you can see, especially in males, that the physeal plate has not totally fused yet. And because of that, and it's so interesting, there's so much destruction proximal, but look how it's completely left the epiphysis and totally intact and normal, knee joints totally normal, because the neoplasm needs the blood supply in order to proliferate, and the cartilage of the physeal plate, being avascular, doesn't allow it to penetrate and to go into the joint. I'm going to digress for a quick second and tell you that this is a key differential feature between neoplasm and infection. Infection will tear through cartilage. Infection will tear through a joint space. Infection will tear through a fat pad. And tumor will not. Tumor will not go through any cartilaginous barrier. It won't go through the epiphysis. It won't cross a joint space. It has to do it in other ways, but there cannot be direct extension. Infection will not respect any borders and will just tear through it. So in that way, infection is kind of more aggressive in that way than neoplasm. This is a very aggressive classic cumulus cloud appearance of osteosarcoma in the knee. Okay, so that's going to be osteo. Next is cartilaginous, and here we're going to use the term chondro when when describing it. This is a chondrosarcoma. Very aggressive tumor as well. This has happened in a somewhat older age group. Again, give and take, roughly 20s to 30s, maybe 35. So a good rule of thumb is primary tumors tend to happen under the age of 40, and METs tends to happen over the age of 40. So 40, 45 is a good rough dividing line as to when you're going to see primary tumors versus metastatic. It's extremely rare to get metastasis in someone under 40. So very doubtful that you're going to see anything in metastasis in patients under 40. This person's probably in their 30s, maybe late 20s, early to mid 30s, and you can see that the proximal humerus is completely blown away here. But look, it's a very different pattern than osseous. Cartilaginous tumors, where the bone is being replaced by neoplastic hyaline cartilage, tends to give you, I'm just going to get to my pointer here. Yeah, these areas of flocculent or stippled calcification. That's the way neoplastic hyaline cartilage tends to calcify or ossify. And the lay term for this is popcorn type of calcification. So this popcorn or flocculent is the correct term, or stippled calcification, very characteristic of a cartilaginous tumor. Now, that's true whether it's benign or malignant. This one has to be malignant because you can see how it's just blowing away the complete proximal humerus, which doesn't exist anymore. Again, look at the glenohumeral joint. This entire proximal humerus is completely gone, yet glenoid surface is fine. Shoulder joint itself, the actual joint is fine because the cartilage is preventing it from progressing. If this was an infection, osteomyelitis, then within hours, this would probably become a septic arthritis, and it would just tear through and start to affect not only the joint, but cross the joint into the scapula. But because it's neoplasm, it respects the cartilaginous barrier, and despite the dramatic aggressiveness here, it's left the joint space alone. Okay, so that's cartilaginous. Chondrosarcoma. Now, fibrous and fluid field look the same, and it's hard to tell the difference on plain film X-ray. Maybe an MRI or maybe a biopsy to actually tell us. We'll kind of put fibrous fluid together in the same category, same section. And here we're going to see a lesion that doesn't have calcification, that doesn't have internal septations. It's lost a trabecular pattern because now you're replacing osteocytes with either fluid in a cyst, or in this case, this is fibrous dysplasia, fibrocytes, which are obviously going to be softer and more flexible. And that's why you see a bowing in the long weight-bearing bone in fibrous dysplasia. And what is the nature of or the consistency of this type of tumor? It's as if you took, if you can imagine taking a little wad of toothpaste and massaging some sand into that toothpaste. That's basically would be the consistency of this type of tumor, where the toothpaste is represented by the fibrocytes, and the I guess, the eroded, enzymatically ruined bone tuberculation would be kind of that dust of sand, the grit that would make this appearance appear the way it does. It's referred to as the ground glass appearance classically. One of the other terms that I picked up when I was a resident at Los Angeles College was the frosted mug appearance. So I guess that kind of people can relate to it more. When you really want to take partake of your favorite beverage, you put the glass mug in the freezer for a little bit, and it gets this film of condensation around it. So it's translucent but not transparent, and that's kind of the look that we're looking at here of this fibrous lesion. Okay, and fluid filled. Again, simple bone cyst is going to be filled with fluid. You cannot tell from this X-ray whether we're looking at fluid filled or fibrous filled. You might need MRI, or again, you used to take a biopsy. One of the other ways they used to tell is if a person came in with a pathological fracture because there's a very thin cortex. If you can imagine that this little fragment of bone was pushed into the lesion, you would take two X-rays at the time. You would take a standing X-ray and a recumbent X-ray. If the little fragment of bone stayed stuck in what was fibrous lesion and didn't move, then you knew that the lesion was fibrous. If on the standing X-ray, the little fragment of bone would kind of drift its way down to the bottom of the fluid because of gravity, it's called the fallen fragment sign, then you knew retroactively after the fracture that yes, it was filled with fluid. Before the days of advanced imaging, that's all they could do. All right, let's look at periosteal reaction. We're going to move along because I want to definitely finish the 12 sections here. So it might take a couple minutes or we'll be bored, but we'll do the best we can for you. Okay, I know that periosteal reaction is kind of misunderstood by some people, and I made this diagram to make it a little bit easier. This is kind of the only histology we're going to get into. So if we look at this cross section of bone, medullary bone, the cortex on either side of it, and then the two blue layers, dark blue and light blue, stand for the periosteum. Periosteum is 2 cell layers thick, an outer fibrous layer, and an inner layer called the cambium layer. This is the area of the layer where the cells are lay down new bone. Now this happens normally in the case of children growing so that the bone expands. It happens in the case of fracture healing when you get the callus formation. And then it also happens when the cambium layer is irritated by some type of internal pathology like infection or tumor. Okay, so a couple of rules about periosteal reaction that are important. Number one, and the first rule is you never see periosteum. You do not see periosteum on X-ray. You see the reaction of the periosteum. What is it reacting to? It's reacting to mechanical irritation. Mechanical irritation. And how does it get that mechanical irritation? Rule number 2, the cortex must be broken. You may not see the break in the cortex, but if you see a periosteal reaction, then for sure the cortex is broken. As you can see in the diagram, let me get over to that pointer. There we go. In the medullary bone, if there's a fracture, it'll be blood. If it's an infection, it'll be pus. If the neoplasm, it'll be tumor, but it eventually works its way through the cortex, breaks through the cortex right here, and touches that cambium layer. As soon as it touches the cambium and pushes on it, that, for lack of a better word, and excuse me, innately causes the cambium layer to lay down new bone. That pattern of new bone, that's the periosteal reaction. And the pattern in which it lays down the new bone, and we'll talk about the pattern in just a second, is an indicator of the aggressiveness of what's going on, aggressiveness of that lesion. Okay. So there's basically 3 patterns of periosteal reaction, and solid, laminated, and spiculated. We'll leave Codman's triangle for now. Solid, laminated, and spiculated, and this is again a range going from the least aggressive to the most aggressive. Solid periosteal reaction is still aggressive because there's still a cortical breakthrough, but it's going to be the least aggressive. You're going to see this more in things like chronic infection. Laminated, that's the onion skin periosteal reaction. You're going to see that in exacerbation and remission type infections. Ewing sarcoma is one that loves that classically is the onion skin periosteal reaction. I'll show you that in a moment. And then spiculated is the hair on end or sunburst reaction that we saw earlier in the jaw, that's the very aggressive type of lesion. So let's have a look at a couple of these. Okay, so what are we looking at here? We're looking at the distal radius, and we see a solid periosteal reaction. It's a solid band, kind of not that regular. It's fairly regular, but you can still see a bit of kind of undulations. And remember, again, this is 3 dimensions. It's going around. It's a collar of new bone, just the way you fracture would heal with callus. Here we have it with this chronic infection of a localized area where the cortex has been broken and the periosteum, the camera layer, has been irritated slowly. So it allows the bone to grow in a quote unquote normal pattern parallel to the axis of the long bone, very slow growing. What are the arrowheads pointing to? Another clue that we're looking at a localized infection. It's kind of ill-defined, hazy. You might even say it's moth-eaten. So what we're looking at here, the combination of the moth-eaten matrix along with the solid periosteal reaction, we're looking at a local osteomyelitis, a chronic osteomyelitis of this person's distal wrist. Okay, laminated, that's the onion skin periosteal response. And here in this diagram, we can see, so that again, there's periods of exacerbation, remission, exacerbation, remission. And let's see if we can see right here, we can start to see a couple of layers of periosteal reaction. A little bit here, there's lucent, sclerotic, lucent, sclerotic. Classically, again, you're going to see this or on board exams, you can see this on things like Ewing sarcoma. So this is a kind of a middle of the road type of aggressiveness. Let's move on. Spiculated, we saw that in the jaw. I've got another example here. This is another osteosarcoma, and this time, instead of it in a flat bone where you have it radiating from a point, so you're getting that sunburst reaction, this is the hair on end or whisker appearance, where now the pillars of bone are actually at 90 degrees. They're perpendicular to the shaft of the long bone. That's an extremely aggressive lesion. Where's the periosteum here? We don't see the periosteum. Where should it be? The periosteum, I'm going to outline where the periosteum is. Okay, that's the invisible periosteum. And what we have here is, why are we getting these vertical pillars? And remember, again, 3 dimensions. This is going all the way around the bone. Because what's happening is the bone, the neoplastic bone in an aggressive osteosarcoma is going so fast that it's pushing up the camera layer, laying down a couple cells, pushing up again, and it only has time to lay down a couple of new cells before it's being irritated again and laying down more cells. It doesn't have the time to form the regular solid type of periosteal response that we see in a slower growing lesion like that infection that we saw back in the wrist. So that's why you're getting these columns or pillars of bone, and again, coming straight out at you on fast and all the way around. Codman's triangle is really just the edge of where the periosteum is being lifted off of the bone. That's all it is. You can see it in any of the types of periosteal reaction. Here we see it in the spiculated type, but that's all we're looking at there with Codman's triangle. And there it is on the solid periosteal reaction. It's just where the periosteum has started to be lifted off. Again, we don't see periosteum. The periosteum is here. The periosteum is right along here, and then here the lesion is starting to lift it off, and it's laid down this new bone slowly, and that's periosteal reaction here. And again, sorry for my drawing here. Again, 3 dimensions all the way around. It's a collar of new bone. Okay, good. We're coming up on 8. We're just about done. 10 is joint changes. Articular changes. Remember, I mentioned that tumors will not usually cross the joint space. Infection will cross the joint space to involve the opposite side. And when you're assessing any of the arthritides, and we'll get into some of those in the next session probably, you want to look at joint space changes. Are they concentric? Are they uniform? Are they bilaterally symmetrical? Remember, asymmetry in osteoarthritis and bilateral symmetry in rheumatoid arthritis. OA likes the distal interphalangeal joints. RA likes the proximal interphalangeal joints and the metacarpophalangeal joints. So, you know, the joint changes are going to be important when we're talking about differentiating between the types of arthritides and arthritic changes. Okay, soft tissue changes. We're looking at displaced or obliterated myofascial fat planes. We'll look at that. I'll show you some examples next week. The tumors tend to displace the fat pad, and infection tends to, again, just as with a joint, tends to eat right through the fat pad, work through it, and move on into the muscle and into whatever adjacent tissue there is. So again, infection looks a little bit more aggressive there. Okay, Also, we have to consider changes in soft tissue density. This one's a little bit strange. It's unusual. It's not common. Remember the radiographic densities. There's basically four main natural radiographic densities, right? There's air, there's gas, air and gas, right? There's fat, there's water and muscle, and then there's bone. And then the fifth density would be metal in case of things like surgical staples or other artifacts, okay? So when we're looking at the densities, we want to see densities that should normally be there. Here, we see in this proximal thigh, there's air density or gas density in the proximal thigh. So there's a couple of reasons why you might see that. Anybody want to type in why we might see gas in the proximal femur, gas or air in the proximal femur? We're just about done here. We'll wrap it up pretty much on time. Infection, good. Yes, that's an excellent reason. Yep. Like necrosis, yeah. This is actually, that's what this is. This is infection. This is gas gangrene. This is an infection, internal infection, that where the microorganism is producing gas, and that's where you're seeing gas in different patches throughout the thigh. What's another reason why you might see gas in the soft tissue? Or air in the soft tissue? How about atmospheric air? Why might we see that? Post-surgical? Yeah, okay, that's it. Yep, yep, surgical. So trauma, surgical is trauma. And yes, what about an open fracture where, you know, the bone is exposed? Yeah, penetrating injury, yep, common unit fracture, good. Yeah, those are the reasons. So basically internal infection or an external trauma causing an open fracture, which allows air into the soft tissue. That's good, excellent. Okay, okay, we're just about done. And we're coming up, yeah, we're right on time. Okay, so number 12 of the 12 points steps, clinical data is always going to aid in the diagnosis if we can't tell right from the x-ray what it is. Age, right? Most tumors have an age range predilection, most lesions. We already mentioned one of them, Mets over 40, primary tumors under 40, for example. Sex, gender predilections, males, Paget's more, ankylosing spondylitis more in males. Some diseases prefer male gender, females, RA, systemic lupus tends to occur more in females, osteoporosis, postmenopausal osteoporosis, racial predilection, yeah, sickle cell anemia in the Black population, in the Oriental population, ossification of the posterior longitudinal ligament. Personal history, is there any, and family history, any hereditary conditions in the family that you want to consider? Certainly additional imaging, now that we have that technology, CT, MRI, might be helpful. And of course, lab evaluation is also a very important tool. Rheumatoid factor, HLA-B27, you might remember for ankylosing spondylitis, those type of things. And ultimately, biopsy, it might be a histological evaluation is really the only, might be the only final way to diagnose what we're talking about. Okay, I think we'll leave that for next week. We'll do a little bit of how to write a report, and we'll get into some cases. So yeah, I think we'll leave it at that for right now, and I appreciate your time. Certainly any comments you can provide to Davinia, how you found the session, and hopefully you'll join me again next week at the same time. And if you liked it, tell your friends and colleagues, and the more the merrier. Davinia, I'm going to turn it back to you now to make some closing comments. Thanks, everybody. It's been my pleasure.
Thank you, Dr. Daltov. Yes, we will be putting together an evaluation form. So throughout the series, everyone can make their comments. And if anybody else wants to register, they're free to do that. We will be sending the recording out to all registered participants tomorrow, so that they don't miss out on the first session. So yes, thank you, Dr. Daltov. We appreciate your time, and thank you to all the participants. We'll see you next week.
Appreciate it. It's been my pleasure, and certainly any feedback. Oh, I do want to give you my email address in case you do have any questions or comments. I'll put up a slide next week so that you can have it. For anyone that wants to take it down now, it's I'll put it in the chat. For a second. If you have any questions at all regarding X-ray, technical, diagnostic, whatever, that's what I'm here for. That's how I contribute to the discussion. And let's put my email address in there for you, marshdale@yahoo.ca. Okay, any questions at all, no matter what. And if I don't have the answer, I'll get you the answer. There is no such thing as a stupid question. Some of my answers may not be great, but I'll always try my best to get the best answer for you. And again, I want to be your X-ray resource as much as possible in whatever way. Okay, so we'll leave that email address there for you, and we'll see you next week. Take care, and everyone be well.